Welcome, everyone. I'm Shayma Kazmi. I'm a thoracic medical oncologist at Cancer Treatment Centers of America. I'm here on behalf of Total Health Conferencing. The topic I'd love to discuss today in 15 minutes is surely not enough, is the importance of genomic testing guidelines in oncology. As we all recognize, the flurry of genomic testing has been really a game changer in oncology and oncology treatments. However, as fast as we have been testing, the platforms are increasing in number, the complexity of the testing has gotten insurmountable, and we really have not established any guidelines in terms of the appropriate testing or the interpretation of this. So this is a topic very close to my heart. So it begins really with the Cancer Genome Atlas project. We know that this was undertaken back in 2005, so really not that long ago. And the idea was to map the human cancer genome. Now, this project was amazing, identified new oncogenic point mutations, fusions, and variants that have therapeutic impact in cancer patients. And so the earliest, idea of precision oncology or the implementation of precision oncology, I would say, was the use of tamoxifen in ER-positive breast cancer. The first molecular targeted, or really what we consider precision medicine targeted medication, was trastuzumab, which targets the HER2 in breast cancer initially, and now we know that that's being targeted in other cancers. That was back in 1998. And imatinib, of course, BCR-ABL in chronic myelogenous leukemia in 2001. In the ensuing 20 years, really the number of actionable alterations with a corresponding targeted therapy has grown exponentially, includes both single genes such as BRAF and ALK, and composite gene signatures, as we know, mismatch repair and homologous recombinant deficiency. So this is really just a snapshot of how we got here. As you can see, 1971, tamoxifen was first used in estrogen-positive breast cancers, and in 1998, trastuzumab, and as you can march it along, you can see the imatinib for BCR-ABL in 2001, and really in the lung cancer field, 2004 was a game changer with the first targeted therapy for EGFR mutated non-small cell lung cancers, gefitinib, and then KRAS was identified in 2006 as a potentially actionable target, though KRAS wild-type patients benefited from cetuximab. The opposite is generally true for mutated patients, such as BRAF. Then PD-L1 has really been the immunotherapy game changer, initially with non-small cell lung cancer, and now really becoming more prevalent in use in other malignancies, and that really started in 2014. And then the gene signatures, they're a composite like MSI, microsatellite instability. And then we find really, really rare mutations such as NTRK, which are tumor agnostic. So bottom line is really, when we isolated the first oncogene in 1982, gene expression profiling for chemotherapy selection began back in 2000. As most of us remember, that really didn't pan out. I know that we used to use testing to essentially isolate the chemotherapies that may be most effective for malignancies, and none of that really was able to be proven to be beneficial, and it's fallen out of favor when NGS technology really took off in 2005. 2011 is when Foundation one of the FDA approved NGS technology, and 2014 was MSK Impact. So these two are of course, FDA approved, and then CMS NGS funding guidelines came out in 2018. We know that FDA approval happened for Foundation 1, MSK Impact, Oncomine CDX, Target, Praxis, RAS panel in 2017. So this list, again, is not meant to be exhaustive in any way. There are many, many more NGS platforms, but these are probably the most well-known and probably the most utilized not next generation sequencing platforms. You can see the Foundation CDX, for instance, assesses 324 genes. It has an FDA approval, and these are sort of the mutations it predominantly checks for. MSK Impact comes from Memorial Sloan Kettering, assesses 468 genes, also FDA approved, and then all of the mutations it analyzes. There's Oncomine DX target test, Caris, which probably analyzes the most genes, 592, and has a partial FDA approval. The other ones listed here do not yet have FDA approval, though they're absolutely used throughout the country. Oncomine, TrueSight, Foundation One Liquid is utilized more frequently in Garden 360. So these two are not tissue-based, of course, they're liquid biopsies, and they're coming into favor as we understand, tissue biopsies are more difficult, invasive. And if we can find a way to easily assess these patients with a blood test, of course, that's preferable. Now, this list, of course, is absolutely not exhaustive either, but it's meant to give you a huge appreciation of how far we've come. Maybe some of us are histology-specific practitioners. May only see, say, lung or GI or breast, but really this slide gives you a sense of how many targets we have currently with therapeutic agents approved, not just in the pipeline, but actually approved. So I didn't even put the targets that are in the pipeline because there's no way it would fit on a slide. But as you can see, there's ALK, BRAF, BRCA, c-KIT, EGFR, and HER2, and FGFR, homologous recombinant deficiency. In fact, just the last couple of weeks, we had dostarlimab, approved for HRD, uterine cancers, c-KIT, and then MMR, which is, of course, tumor agnostic, and NTRK, which is tumor agnostic. And the list really goes down. Again, the idea is for us to appreciate how many targeted agents there are that are available for our patients, and how often these agents are far more effective than traditional cytotoxic chemotherapy, and really gives you the sense that this will be really the future of oncology. Now, there's limitations of next generation sequencing, right? So this is not perfect. It's evolving. We know a lot of information. We understand that tumor heterogeneity, which may be static or dynamic, really means that you could biopsy, one of the 5 metastatic sites and may have a different genomic profile than maybe the primary tumor or other metastatic sites. And dynamic really means over time, the tumor isn't going to be staying the same. It's going to change. It's going to mutate and have more mutations or less, depending on the treatments. There's different sequencing techniques. Of course, the adequacy of samples, as we talk about tissue biopsies, becomes a real problem. Patients with bone metastases, for instance, when you decalcify bone, really is difficult to run a next generation sequencing, or cytology samples. We really haven't verified a lot of this testing on cytology samples. So we know the DNA extracted from fresh frozen tissue older than 7 years are not adequate. So for patients needing new biopsies, this can be a challenge. There's also cancer-associated mutations in normal tissue. So how do we really verify that the mutations we're getting are actually malignant and within the cancer and actually are driver mutations and not just incidental findings? And of course, lack of real-world data, right? A lot of these trials, we have a very, very small in certain tumor types, and really how do these pan out in the real world? We really need to know how do patients tolerate this and how do they respond. So these are the current, and some of them might have closed already, precision medicine trials, to also give you a sense of how many clinical trials are underway. The French Shiva trial phase was the first precision medicine trial that really was actually a negative trial, and maybe it was patient selection. The Moscato 01 was a positive trial. My Pathway is a basket trial that's still ongoing. Novartis signature program. The ASCO-sponsored TAPER study is still ongoing. There's multiple other precision medicine trials on here. The lung map trial, for instance, the Alchemist, just to tell you that we're really, really in the infancy of discovering targeted drugs and really trying to analyze them for multiple cancer types. Up until now, we've really just identified tumors based on the origin organ, breast cancer, lung cancer, colon cancer. And I think that in the future, based on this, we might have to have gene signatures as sort of the identifying tumor type. So the most important question here, and that's one that we grapple with frequently, is when to test a patient with next generation sequencing. And really then the second question is, which test do we use? But multi-testing would be great if it was insurance approved. For instance, many of our patients need testing initially a diagnosis, and then they may need testing as they have, of course, responses or lack of responses, progression of disease, and possibly resistance mutations. There are rare molecular alterations, but exceptional responders. So going to look for NTRK mutation, for instance, it's super, super rare. It's really the needle in the haystack. I haven't found it yet. But you have to look because patients who get NTRK targeted therapy have such high response rates and also long duration of response. So to find that exceptional responder, we really have to really test so many people. There's certainly rare cancers. Those are almost easier to recognize that, gosh, we should test those patients for sure who have really limited options of therapy. And then, of course, clinical trial networks. So many basket trials. We talked about so many genomically driven trials out there, and really important to test your patients early on to see if they would even be eligible. And then, of course, clinical judgment. If you have a patient with good options of therapy, but they have progressed through first line, second line, and you really think that there may be something else out there in terms of targeted therapies, you should be able to use your clinical judgment, of course. So this is, again, a schematic, a general, vague proposed guideline. Remember, we don't really have any guidelines clearly, NCCN or ASCO, but really it's not indicated in early stage cancer undergoing definitive therapy, right? What's your sequencing going to yield in that patient, unless it's for a clinical trial? Occasionally indicated in advanced non-small cell lung cancers, of course, if it's early. So, of course, with Tagrisso osimertinib approved in the adjuvant setting in non-small cell lung cancer, we do need to now test, at least for the EGFR, in those early lung cancer patients. Now, some advanced rare cancers, it's indicated clinical trials and exceptional responders. If you're really looking for those mutations that may have exceptional responses, it is not indicated in rapidly progressing cancer. And one of the reasons for that is the turnaround time for most of these platforms can be a couple of weeks. And by the time you get the results and then you try to get targeted therapy, patient may not be able to benefit from it. Poor performance status, of course, that eliminates most patients from clinical trial enrollment and possibly from getting therapies because they may not yield a response in time or tolerate these. And then short expected lifetime along the same lines. So the future directions that I'd like to think about, in terms of where we're going, is we need to really secure more funding for NGS testing. Right now, a lot of the newer platforms will do this for free until they get approval because they're looking to get some data. But whether it's the government that's going to fund testing, whether it's insurance companies, and how many tests can patients have, and who determines those guidelines. Right now, we have a lot of restrictions, so you really have to be wise in terms of when you're using the testing. And then really improving test reproducibility and quality. Are these tests interchangeable? Are they different? And if so, how? And what are some of the quality data for these tests? Really, really important in terms of also pathology, prepping the tissue for these tests, really guidelines for that. NCC and ASCO really need to come up with some algorithms, guidelines for appropriate testing. Again, not rules necessarily, but guidelines for the practitioner, oncology practitioner in community setting, for instance, and also being able to predict therapeutic benefits. Right now, we do get testing a lot of times, and then you look at the results and it's hard to interpret. We don't really know what they mean. We really have to contact the company then to potentially discuss in a molecular tumor board, which not every oncologist may have the bandwidth for. So it'd be really great to have more streamlined publications, real world data for prediction of therapeutic benefit of some of these rare mutations. So with that, I will leave you with more questions than answers. I wish I had a website or something to refer you to, but really I think this field is going to explode over the next few years and a decade. And I'm looking forward to a more streamlined approach to benefit as many patients as we possibly can, really, with this testing. And that's really the ultimate goal. So thank you, THC, for giving me this opportunity.